Rob, welcome back. Tell us what's going on.
Sure, absolutely. Thank you. By just way of introduction, we're in room 1 at Mount Sinai IR lab right now. To my left, who just danced over, is my colleague, partner Rahul Patel. Now to my left is, again, one of our great integrated IRDR residents, Alex Schur. And then right off the screen, again, another one of our great integrated IRDR residents, Justine Aziz, who hopped over with me from the first case. We have an interesting case. I think it dovetails into the sharing cross conversations that I couldn't help but overhear. I'm looking forward to input from the entire panel. Before we get started, again, I just want to thank everybody here at the IR lab at Mount Sinai. We have just the best techs and nurses, the incredible anesthesia team, again, our AV crew, BroadMed AV, who've just been really working hard to get this done and allow us to present this. So I think Alex has a PowerPoint presentation. He's going to give you the history, and then I'll editorialize it a little bit. And then I'm, again, looking for input from the panel about what to do next.
This is our patient. He's a 65-year-old, history of COPD, metastatic lung cancer with brain mets, had a partial lung resection, craniectomy in June. He also had a history of PE, and he's on Eliquis. He's had a history of PAD with bilateral rest pain, where we first saw him earlier this year. On exam, he has 1+ femoral pulses in the right, absent popliteal and pedal pulses in the right. He had a monophasic duplex waveform in the right PT only. His ABI before his index intervention was 0.4 at rest in the PT. He had a CTA that demonstrated bilateral external iliac disease, bilateral SFA occlusions, and a single vessel runoff bilaterally. A month or two ago, he had underwent a left lower extremity revascularization, and they also performed a diagnostic right lower extremity angiogram, which demonstrated some multifocal external iliac artery occlusions, multifocal external iliac artery disease, a long segment SFA, total occlusion, and some multifocal infrapop disease. And given his persistent right lower extremity symptoms, he's now presenting to us for a right lower extremity angiogram with possible intervention. These are his meds and his smoking history. This was the diagnostic angiogram performed from the index procedure, demonstrating a flush SFA occlusion and that focal right external iliac stenosis. This is just kind of showing where the popliteal artery reconstitutes, just kind of at the adductor canal. There's also a severe TPT trunk lesion with single vessel runoff via the PT and some collateralization at the ankle via the perineal. So in summary, this is a 65-year-old history of metastatic lung cancer with brain metastasis with bilateral rest pain, previously revascularized on the left, now presenting with persistent right lower extremity ischemic pain, and multi-level occlusive disease. In terms of options, we had discussed optimal medical therapy, his optimal anticoagulation and antiplatelet regimen, surgical bypass, and endovascular revascularization. And I'll pass it on to
Yeah, sure. So I met this patient 3 months ago, and again, this really does, I think, go to the previous conversation. He was referred to me for rest pain. He has, monophasic Doppler signals at his ankle. He has, real rest pain, can't sleep, very severe. And I spoke to his oncologist extensively. The oncologist is telling me that he's likely going to live for another, 18 months, maybe 24 months if he's lucky. He works every single day. He works here in New York. It's his method of livelihood. It's how he supports his family. And he said, I can't work because of the pain. I need to work, and I need you to help me. And so that's where the conversation started. And again, I know this is somewhat of a unique case, but this was somebody who said, I'm going to work as long as I can. I need to work. There's a real need there, and I can't function. I can't sleep. I can't ambulate. I can't do my job. That's where we started this. I obviously talked about him, about all of the lifestyle modifications that I think would be intrinsic to this. He objectively stopped smoking after I saw him. I can't track that to 100% confidence, but I told him I didn't want to get involved with his care unless he agreed to stop smoking. That was the first thing. And then we really went through doing nothing, leaving him alone. We went through bypass, and we ended up with his desire to be able to work. And that was the primary conversation. And the major focus was his ability to take care of his own affairs, his ability to be able to provide for himself and his family. And he asked me to do whatever I could to get him back to work as quickly as possible and to allow it so that he would have the least likelihood of needing to return. We did map his saphenous veins, just to be very clear before we get into that. And one side had been ablated, and one side was, very, very varicose, greater than 7 millimeters, 8 millimeters, a very, very chronically inflamed, diseased vein, and it was not of a long enough segment to be able to accommodate this. It would have needed to have been spliced. So we did assess the saphenous vein. We were consistent with the bypasses. But again, I sort of will open it up to everybody else about how they would manage a patient like this, who is clearly debilitated in terms of their lifestyle from ischemic pain. They don't have a long life expectancy. That's clearly the front and center here, but has a very strong desire to work, is very functional now, is working every day, and wants to be able to, continue to work and without hesitation and provide for himself and his family.
Yeah, I think, Rob, you have convinced us. There is absolutely no question about that. The guy is suffering. I think rest pain is really no joke. And even with the potential life expectancy for this sad patient, to ease his suffering at the very least, I think is absolutely correct. Just quickly in our panel, even if his veins were good, to be honest, I would try an endovascular approach. I don't think I would try an open. Anybody on the panel would offer him a bypass even if with good veins?
I love a bypass. And I think in metastatic cancer, I always think that the durability, even if it's the perfect vein and it's the perfect inflow and the perfect outflow, there's some inherent hypercoagulability. And I find that my bypasses just don't do as well. And so in a situation like this, I think for me, endo's the way to go.
Rob, it's Moriarty. Did you get a vibe from either yourself or his oncologist as to whether he would tolerate antiplatelets and anticoagulation going forward, or do you feel this is a guy who will probably fail it given all his, potential bleeding sources? Yeah,
so that's a great question. So he's on therapeutic Eliquis right now. We had the discussion that we were going to add single antiplatelet therapy, but we felt that dual antiplatelet therapy was likely just reckless. And we're choosing against that. And so he's on monotherapy right now, in addition to the Eliquis. He appears to be tolerating it. We spoke this morning. He's not complaining of any bleeding symptoms, no bloody gums, no bloody noses, nothing like that. I understand we're, again, sort of being, proceeding very cautiously given his medical history, but at least right now he's tolerating monotherapy. And I think monotherapy is probably the right thing if we want to really talk about a durable endovascular repair.
Rob, could you just really quickly comment? You mentioned a CT scan. We didn't see it.
Yeah.
The angiogram is suggestive of calcium. Was the CT pretty heavily calcified, or is this mixed morphology?
I would say it's more mixed. It is not dense. We'll go through the angiogram in just a minute. This is mild to moderate calcium. This is not a ESRD patient. So I'm not trying to, make it out like that. This is more, I think, severe athero with a mild to moderate amount of calcium. And I have intravascular imaging to show you that will confirm that in just a moment. I'm going to let my colleague Rahul Patel go through the images of what was done before we went on camera.
Yeah, so we basically got contralateral groin access. It's just an omniflush to the pelvic angiogram. That external iliac lesion doesn't look as bad as it did on the previous angiogram. So I'm not sure if it was a fake out from the previous, but I think we decided that we'll work through it and then decide about whether to intervene on it later, because it doesn't seem to be affecting the inflow, at least for the intervention. So this is an AP of the groin. You can see a profunda, not really a nub, but we'll get to that in a second. This is sort of P1 coming back, so long segment SFA CTO. And you can see, sorry, I can't get the bones on, but there you can see sort of the beginning of the TP trunk and the bifurcation there into the perineal and the posterior tib. Here you go. Here's that. A little bit better. A little bit of an AT dribble, but nothing. Not primary runoff. It's really the PT and the perineal, and here's sort of the lateral foot. This runoff doesn't look that different than it did from the previous angiogram. So what we did is we did a sort of a actually go to the next one. So this is with the destination, 6 French destination, up and over a steep RAO, and you can see sort of the nipple or the nub of the SFA. So it's flush, but not totally flush where we weren't going to be able to engage. So what we did is we took a VER catheter, so just an angled catheter, sort of oriented it into into that nub. And then what we did is we actually just tried to cross with the Benson. So that's sort of my go-to first attempt to cross. It kind of eventually poked through. I think maybe this one shows it.
So you see the wires crossed in a couple of centimeters.
Yeah. Sorry, go ahead, Vanita.
You first start with just a Benson, just kind of probing the takeoff a little bit. You're not jumping right to a different kind of wire.
Yeah, I find the Benson to be basically relatively forgiving. So if it goes, it goes. If it doesn't go, it doesn't go. And then I can switch to a glide wire. But if it goes, it goes pretty well. So you can see here.
To echo that, the nice thing about a floppy tip 3.5 wire is that it's virtually guaranteed to stay true lumen. And so it's a little old school, I would say, and I'm the old person here in the room, just to be clear. But we find that if we even spend 1 minute trying with a floppy tip 0.35 wire, it's more likely to stay true lumen, and we'll actually show you in a minute with intravascular imaging that actually bore out.
Hey, Rob, it's Leanne. Did I miss it, or did you access through a stent in the common femoral on the contralateral?
No, so actually we made a point to under ultrasound and then under fluoro to make sure we sort of accessed in between the two. So we accessed the common femoral in between. So
and there is no stent in the common femoral. The stent is a stent that goes up to the ostium of the SFA, and then there's a external iliac artery stent. The common femoral and the origin of the profunda are wide open. We don't stent the common femoral.
So this is a Benson again, just sort of walk it way down. So you usually get to the floppy part, and then once it starts to buckle over, you don't let it actually buckle over, and that's sort of where you stop. You bring the diagnostic catheter back down to that spot, and then sort of pull back and probe again. And this is, again, just the Benson, just walking it down. Nothing super fancy here.
In the era of all our fancy tools that you're just doing
it's my $8.
Yeah, it's the $5 crossing tool.
It's my $8 Benson here. Yeah. You can see we got, this is actually a quick cross. We got a little stuck, so we switched the vert for a quick cross, 035 quick cross, which we got. So you can see we're basically right there. Eventually we were able to poke through. And we were able to get through. So no reentry device, no fancy wires or catheters, just an $8 Benson and a quick cross probably. So that's it. So we're here, we're basically got there. We switched that Benson out for a Grand Slam just because of what we're going to planning to kind of do later on. Ballooned, this is just a 5 balloon. So you can see this is, I think, the 6 balloon. Sorry, this is the 6 balloon. You can see kind of where we're getting some tight stenosis there.
Did you IVUS before you ballooned, or you're just pre-dilating everything?
We pre-dilated everything, and so this is actually after the balloon. And then actually, now we can go to the IVUS. So can we show the IVUS? Let's see here if I get this. So this is actually coming retrograde. So we're coming from the PT up. And so I'm going to kind of run through this. So you can see the PT here.
And the TP trunk is right there. So it gets very, very, very tight. You can see that with the calcium. And you see the calcium there in the again in the baloney. Now we're getting up into the P3 of the pop.
You can see it's kind of definitely some calcium there.
There's the pop.
There's the pop.
And you see there is mixed intimal calcification, medial calcification. It's not the most severe case I've ever seen for sure, but there is calcification throughout. You see it's a little bit more pronounced as we get higher up. You see that even though we ballooned with a 6, there were areas that had recoiled immediately. And again, I think you'll all appreciate that we are true lumen the whole way. There was no subintimal passage anywhere.
And then now we're
I would agree. I'm really digging the Benson idea. Why don't we pause here? You have this long segment occlusion that you just made look so easy. You just passed with the Benson. We're seeing the plaque morphology on IVUS. I'd love to go through our panel and just get some how I would kind of approach this. Sean, should we start with you? What's your sort of go-to algorithm for this kind of lesion?
I love the Benson trick. Also, the Newton wire works great as well. I would consider distal protection and maybe some kind of vessel prep, like with potentially laser and then drug-coated angioplasty.
Leanne?
Yeah, I hate putting a filter down, but in this case, with how easily the wire passed, it makes me a little nervous. With the medial calcification, you could also consider IVL-based technology, and then some sort of drug-coated therapy.
Zola?
I agree with Leanne regarding vessel preparation. Probably IVL here and hopefully drug-coated therapy without having to leave anything behind unless needed.
Yeah, I mean, looking at the IVUS, it's mostly that soft fibrotic plaque. There's a little bit of calcium there too, but I think put an embo shield down and I would laser this all day long.
I agree with Jay. I think it's really soft, certainly in the SFA, calcified in the popliteal. So I probably, fairly intraluminal. It didn't seem to be very eccentric with that wire placement. So I'd be attracted to directional atherectomy as well with a filter. Maybe IVL on that popliteal. I'd be tempted for that.
Yeah, nice and very economical crossing there, Rob. That was that CTO.
Just to be clear, Rahul did the crossing. I didn't. He makes it look easy.
John?
I think I'd agree with all that. For want of saying something slightly different, just the immediate kind of recoil after ballooning might make me think that I would eventually end with a stent. But I think in the absence of that, after a drug-coated balloon, I'd leave it at that.
Thinking about his life expectancy, would that push you towards a stent, kind of go faster, stent quicker, get out of there at all? Anyone?
I mean, just if you're worried about thrombosis and things like that too, we're not sure what the long-term anticoagulation capabilities are. If there's any stasis at all, I think the thrombotic risk is a lot higher. So if we can leave nothing behind, and with those dissections, maybe after you've done your prep, you can look at it again with IVUS, and if there's flow-leading dissection, then you do spot stenting, but a full metal jacket probably is not a great plan.
Got it. All right, back to you guys. You want to show us what you've done next?
Yep. So we did IVL. So I'm sorry I couldn't recognize the voice of who said IVL, but clearly we're thinking about it the right way. And we used the new E8 catheter, 6 by 80. And, not to be over jubilant, but I really like the E8. I think most of us do. It made this go very fast. We did the whole length of the SFA in about 3 minutes, 4 minutes maybe. But that was very, very helpful.
Just tell us what the vessel, sorry to interrupt, but can you just tell us what the vessel measured on IVUS that made you choose a 6?
Yeah, so it measured between 6 and 7. I didn't really want to go with a 7. I didn't want to use more than one IVL catheter. And so I felt using a 6 was just going to be a more efficient use of our time, honestly. I think proximally it's measuring about, 6.5, 6.7. Distally, it was more 6.0 to 6.2. So that's how we chose the 6. I don't know if people would have just gone straight to a 7. I was, a little bit, concerned about being that aggressive with an IVL catheter. But so far we've been 6. All right. Obviously, these balloons are semi-compliant. They go up to about 6.5. So that's where we've sort of rested on this. So go to the next run.
You use IVL through the entire SFA for the prep?
Yes. And again, I think
you just thought there was more calcium all throughout, or just use it more as a balloon?
I think it was really more to say that we wanted to. First of all, we had enough charges in the balloon. The calcium was more on the diffuse than focal side, based on the intravascular ultrasound. There was probably an area right in the middle where we skipped over, maybe on the length of about 8 centimeters or so, where we really felt there was no calcium whatsoever. But I think it was a more diffuse treatment than a more focal treatment, if that's what you were going at.
I'll say that I agree that E8 really gives you a lot of treatment zone with 400 shocks. I personally oversize pretty aggressively, though. I would be much more comfortable because you're at low atmospheres to push it to a 7. But looks like you have a great result. Do you want to? Well,
we're sort of getting there, and that's where I think is a really good conversation. So this is where we are now, where we've restored antegrade flow. There was some residual material, and so everybody on the panel who said maybe putting a filter down would have been a good idea, they were right. we did not put a filter down, and so we had to chase it briefly off camera. This was a 4-balloon, 4x150 into the PT, which again was our target. And so here we are with restored flow down the PT. And if I had to guess, there was a small amount of material that was liberated during the crossing or during the vessel prep, and it was probably lodged in at the popliteal trifurcation. And by just ballooning that area, we probably moved it aside. It's either wedged now into the origin of the AT or it's in the perineal as it was before. So the question now, and I think the panel was sort of starting to get to this, is we have probably some residual lesion at the origin of the TP trunk. So the question is, first and foremost, just optimize POBA, DCB, even though that's not necessarily on label, but we do have a 4mm DCB in our lab, coronary DES, bioresorbable scaffold, and then there's some dissections proximally in the SFA. Should we DCB the whole thing? We have an 014 wire down, and we could use the Ranger DCB right now, which we have on the shelf, and see how it is. Or I think there was a previous comment about the moderately short life expectancy and whether or not we should be much more aggressive with just scaffolding him for probably a longer length in the SFA so that he has a less of a chance of coming back to our lab and needing another procedure. This is where we're looking for input. We could go very aggressive and just, cover the whole thing with scaffolds and stents. And, just to be clear, it would be probably something focal at the TP origin, maybe bridging into the PT, and maybe a proximal SFA stent, maybe 15 centimeters. Or we could try drug-coated balloons. What does the panel think we should do now?
Well, we have an expert panel. Zola, you want to weigh in?
Rob, this is Zola here. Fantastic case, very tough patient, especially in the setting of cancer. I recall you had a perineal that's open, which we're not seeing right now.
That is correct.
In order for your SF and popliteal work to be durable, it might not be a bad idea to put a wire through that perineal, aspirate to make sure it's wide open. You might perhaps need a stent there and just deal with the SFA. So that way you have good outflow and hopefully good durability.
All right, so one vote for adding on another runoff vessel, okay?
And was there any thought to re-IVUSing at this point to see what? We
can totally do that. We can absolutely run IVUS. I want to be sensitive to that we're either running out of time or about to run out of time. So I'm happy to do an IVUS, and everybody weigh in on what we're going to do, and we can finish it off camera, obviously. But I think this is a great opportunity for teaching and let intravascular imaging guide us. If anybody else feels strongly, let me know, but we are all set to go with another round of IVUS.
So I would just say, and I'm curious what the rest of our panel has to say, but when that original IVUS run, there was some disease in that TP trunk. You did not treat that with IVL, right? You started in the
that is absolutely correct. We did not. I have personally, I've not had a lot of experience with IVL in the below knee circulation. I don't use it as my go-to. I tend to, I think most people that know me are aware, I tend to be much more scaffold based. And so my usual default is POBA and then either a DRS or an actual DES. It depends on the patient, on the lesion length, et cetera. So we have not been aggressive below knee IVL. I've been much more happy with the results in the above knee segment for IVL.
Pat, you wanted to make a comment?
Hey, Rob, again, excellent job. Just a couple thoughts. It definitely looks like you went from 2 vessel to 1 vessel. So I'd agree with Leanne, perhaps a bolt 6X down the perineal after you wire it. And then my other question for you would be, this seems like an ideal location for the spur from reflow. Can you comment on your experience with the spur? Because I think that would be very efficacious here, given that disease location.
So I've not used the spur yet. We have very, very, very early experience with it. I think it's a great idea. It's a great concept, but we don't currently, have, a wealth of experience to be able to say that, we think it would be beneficial for this kind of a lesion. So you can see, I think on the screen, Flora for a second. I just want to make sure where I am. So I'm in the proximal to mid perineal. I'm going to do a pullback.
Posterior tib.
Sorry, posterior tibial. Thank you. I'm going to do a pullback, and you can see this is, falling apart a little bit here.
Rob, you're in the PT, correct?
Yes, I'm in the PT. I misspoke before. I'm sorry.
That's the perineal.
That's the origin of the TP trunk right there. So that is obviously not looking as good as we would hope. And now we're into the pop. And there's still a lot of plaque burden here. I'm going to go through this relatively quickly. See, moderate amount of calcium, moderate amount of plaque burden.
Jay, were you going to make a comment?
Yeah, I mean, based on the IVUS, I think we're pretty convinced that there's probably some thrombus down there as well, too. So there's probably some luminal thrombus that may have embolized with the balloon inflation. Pat's comment about using 6X, I think would be pretty nice here. It should cross and, try to aspirate that material out. And actually, the rest of it may look better as well, too, with some aspiration.
And one of the ultimate questions is going to be, once you finish this case, the antiplatelet regimen. If this patient has to be on single antiplatelet, if it's clopidogrel, I think it's important to get these people tested to make sure they're truly responsive. So do a P2R12, because if they're not, they won't be on anything. Then you have to switch to something else.
Zola, do you do that routinely or only in sort of the more high-risk hypercoagulable patients, such as a...
I do it predominantly for the high-risk patient, especially this one who's hypocoagulable and issues like this with thrombus. Those ones, I'll definitely do a P2R12 immediately, so we have an idea how to adjust the regimen.
So I think we have some agreement that we would probably chase after the perineal, but just looking at what we see in the TP trunk, let's say he does that, who would put a scaffold, who would leave it alone, who would balloon? Maybe, John, should we start with you over there and go across our panel?
I would start with a balloon and hopefully end there as well, diluting balloon at the TP trunk.
Pat?
Yes, start and finish with the spur from reflow. I think that's an ideal location for that technology.
Jeff?
Yeah, I think the spur's a good idea, but if you don't have it, I would put a drug-eluting stent in there. Yeah, I think it really needs scaffolding with that eccentric calcium. I don't think we have a suboptimal PTA.
Drug-eluting versus spirosorbable. I mean, coronary
either
stent
would
versus-
if you have
either.
it, yeah.
Jay?
Yeah, I want to see what happens after the aspiration and then reevaluate.
I agree with Jay. I want to see what happens after the aspiration because the flow is better. Hopefully we can get away with drug-eluting therapy without having to leave a scaffold.
Yeah, I agree. I'd put a 6X down there, see how much I could suck out, and then I really love IVUS. I think that run was really valuable information, so then I'd re-IVUS again and then decide whether I could get away with just drug-eluting therapy or if I had to scaffold.
I would advocate for aspiration and then angioplasty.
And what about for the FemPop, Rob? What are you guys thinking?
So again, I'm curious as to what the panel thinks. I think there was a lot of recoil, and there's a little bit of calcification there. I'm probably, just to forecast this, inclined to putting at least one stent at the origin, likely to deal with that recoil that we saw up there. I think there's an opportunity for DCB distally, so we don't have a full metal jacket. I don't think I'm getting out of this case without putting at least one scaffold, probably in the proximal portion of the SFA. I'm just curious whether people think that's a bad idea or they think that's just a much more pragmatic way to think about this.
We're getting some nods. Jeff, do you want to weigh in?
Yeah, are you planning on doing drug-coated balloon on the SFA then first?
Yeah, I think what I'm hearing is that we're probably going to send down an aspiration system, run it throughout the posterior tibial, possibly into the origin of the perineal, and then up through the SFA and popliteal. We're probably going to end up drug coating ballooning with a 018 system, probably Ranger, for the entire length of the SFA. If I had to guess, we're going to end up putting in a scaffold at the origin of the SFA. And again, just the way that ostium of the TP trunk looked, I'm guessing we're going to put in something there also. And I want to go back and look at it after the aspiration with the IVUS. If it looks like it's densely calcified and it's a short focal thing, I'm probably going to put in a bioresorbable scaffold.
I will say and maybe it's because, full disclosure, I'm part of the BTK2 trial. I'm a huge fan of IVL below the knee. And to me, that TP trunk lesion did look calcified. I mean, it doesn't necessarily mean you don't need a scaffold, but I would probably aggressively, with the 4 or a 5, IVL that spot after you aspirate.
How much time do we have left? I just want to be sensitive to that.
We have 1 minute and 30 seconds.
All right. So I don't want to get involved with too much stuff, but I think if we could set up the penumbra system, that would be great. All right. So just out of curiosity, what diameter systems would people feel comfortable doing? I think Vanita said 4 for the TP trunk. Is that routine that people are using 4 millimeters for either PrEP or IVL for the TP trunk?
Yeah, I think I get a pretty aggressive in oversizing, and if IVUS shows that it's at all bigger than 3 millimeters, I'll probably pull a 4.
Any other thoughts on how you treat that? So your plan, just so we can sum things up here.
Yeah, absolutely. We're gonna aspirate. We're gonna aspirate the entire length of the SFA and POP. As per the previous comments, we'll probably swing from the origin of the posterior tibial into the origin of the perineal. In full candor, I don't think I'm going to spend that much time on the perineal just because I'm not sure that the benefit is really going to be there. If I can get a durable single vessel into his foot, I'm going to alleviate his rest pain, and I think he's going to feel better. And then the goal is going to be just optimizing the entire FemPop segment. My clinical goal is that before we exit the patient, he has a palpable PT pulse. And that's what I'm going to use to sort of end the case, regardless of what the angiogram looks like. If I can get the pulse pressure in his foot to about 70 or 80 millimeters of mercury, and I can feel the pulse in his foot, I think that's a durable result. I think he's going to clinically benefit from it. I'm hoping it doesn't take more than 1 or 2 scaffolds, but we're obviously going to be prepared to give him the most durable result that we can.
Okay, well, listen, to the whole team at Mount Sinai, congratulations. Thank you so much. I'm sorry we ran out of time. Hopefully
it's okay. It's all good. Thank you for the great comments from the panel.
Okay, goodbye.
Bye-bye. Thank you.
Bye.
Hi, everybody. So we just finished. We wanted to give you an update on what we ended up doing. The panel was incredibly helpful in giving us insight. So to make this very succinct, we did take a 6 French bolt catheter from penumbra down to the popliteal trifurcation, and we ran it through the popliteal artery and the tibial perineal trunk. We were able to aspirate solid material and restore flow to both the posterior tibial artery and the perineal artery. We then placed a bioresorbable scaffold, an Esprit scaffold 375 by 38 into the tibial perineal trunk, bridging into the posterior tibial. We did drug-coated balloons, specifically the Ranger drug-coated balloon, a 7 millimeter balloon, in the mid to distal SFA, and then we placed an alluvia stent pretty much at the ostium of the SFA. The patient now has a palpable PT pulse, and I think we're going to go through some of the images here. We also have intravascular imaging. I think Rahul is going to share that with you.
Yeah, so this is sort of the IVUS images, starting again distally and working our way up. So this is in the native posterior tibial, and you can see it's kind of coming through. Eventually, I think this is the Esprit stent. Sort of hard to see on IVUS, also equally as hard to see under fluoro, but you can see it's there. The flow, the luminal gain is good. This is going into, this is sort of into the, there we go. Now we're into the popliteal, distal popliteal coming in. Still some plaque, but it's significant luminal gain that we had before. Coming back up, now we're getting into sort of the pop SFA. Coming back up, some areas of some narrowing, but it's not that bad. It looks really good. So the question is, do you put more scaffold here? We decided not to. Again, we DC beat all this. There's a little bit of a spiral dissection here, which again didn't seem flow limiting. And then here we're into the alluvia stent that we placed proximally towards the origin here. So just to show you the angiograms now, this is sort of the final run from the destination after we pulled the wire. You can see here there's brisk flow faster down the SFA than it is the profunda. This is sort of sorry, I'm going to back up a little bit. You can see that little dissection there, but the flow, it doesn't seem to be flow limiting. It seems to be antegrade. Even the collaterals now are going in the other direction. So again, just showing that we've got good flow going in the correct direction. This is a popliteal P3 tibial perineal trunk. Again, you can see we still see antegrade in the perineal, even though we did use the Esprit to cover it. It didn't really affect the flow. Posterior tibial is the primary runoff. And again, still brisk flow down to the foot, significantly faster than it was pre-procedure. So ultimately, we decided to just close with an angioseal here, held pressure, and that's hopefully it.
So great case result, great opportunity for multidisciplinary collaboration. Panel's input was incredible. Ultimately, we came up with a great result. I think the patient's going to benefit tremendously. On behalf of everybody at Mount Sinai, thank you to Viva for inviting us. I hope the cases were educational today. Take care.
Thank you. Are we out?
We are up both. Do you want to keep recording the case?
Oh,
Okay. We can
keep talking, yeah.
keep going. That's fine.
yeah, that's fine.
Right. Let's do a full angiogram now. All right.
There you go. Yeah, I understand.
Sorry, can I get the angles right so we can see what we're doing?
Yeah.
Sorry,
Fogging
it's
up.
gonna- Oh, that's why. Nope, I got it the right way the first time. These like foot's really.
What? Lightning? 6? Yeah, lightning 6 we want, right?
Yeah.
Yep, thanks.
Ready?
Yep.
And are we heparinized again? Or...
I gave him a bolus of heparin
okay,
off
yeah.
camera.
Totally
It's
recalled,
just
right?
shutting down. Maybe it is thrombus.
Yeah.
You know.
Yeah.
We also need to draw a ACT.
It's coming there. It just. Perineal's trying to come back.
Yeah, I have no interest in chasing it.
It's right there. You can kind
Yeah.
of.
I know.
I think it's a lot of recoil and then.
I agree.
Thanks.
Oh man, itchy.
Let's try ACT. Here's waist. I have ACT for you, sir.
So you would
Thanks.
just run the penumbra
Yeah.
down the hole.
Probably gonna get something out.
Yeah, no, always get something.
The fact that it keeps on like this.
I think it's just recoil. I think it's just
I
dissection.
think the whole
just
thing is just falling off.
The thing is the
But
question.
but I think there's also a filling defect down there, so I think it's
Yeah.
reasonable.
Yeah.
You know what I mean?
Does she go to?
Do you want to get the lightning 6?
Can't be the lightning. It has to be the 6.
Is it a 6 bolt?
Is there a 6 bolt? I don't think there's a 6
sure.
bolt.
So which one are we in? 6 something?
There's a 6 EX, which is the rapid exchange.
Isn't that the Cat RX?
Cat RX.
Yeah. Do we have that?
It's upstairs. You want me to go up and get it?
Probably.
Yeah.
Get something that's gonna
Yeah.
work here.
Either that or you take the 6. You take the neuro catheter.
Yeah.
Right. It's up to you. If you take the ACE, right, which has no angle on it. Yeah, actually, neither does the Cat RX, but at least the Cat RX.
Is that RX?
The neuro one? No.
No.
Do you want the Cat RX?
I prefer the Cat RX, right? Wouldn't you?
Yeah.
Hey, one. Hey, one.